Now we will discuss some of the miscellaneous topics in endocrinology which is less often discussed but could be a potential source for many questions in the upcoming exams. So an important one among that is the neuroendocrine tumors. So coming to the introduction, as the name neuroendocrine tumors indicate, it is the abbreviation is NET, neuroendocrine tumor. As the name suggests, it has got both neural and endocrine differentiation. Neural and endocrine differentiation. That means the tumor component expresses the markers of neural differentiation as well as markers of endocrine differentiation. Okay. Coming to the history mentioned in the textbook with regards to neuroendocrine tumor, the Otto Lubach was the one who first described the characteristics and clinical features of neuroendocrine tumor, and he identified that the neural and the endocrine components can go together in a lesion. And the Siegfried Obendorfer, he identified lesions which is present in the stomach, and initially he thought it was carcinoma stomach, but the prognosis was not as bad as CA stomach, and he named it as carcinoid, which meant carcinoma-like, because initially it was thought to be gastric carcinoma, but it behaved differently to that of a gastric adenocarcinoma. So he named it as carcinoma-like, and which later evolved into the term carcinoid. Even though we use the term carcinoid to denote the term neuroendocrine tumors, current accepted terminology is that of neuroendocrine tumors and not carcinoid tumors. Now coming to the classification and grading of neuroendocrine neoplasia, these neuroendocrine tumors on histology, if they are well differentiated, that means you get evidences of good neural and endocrine differentiation, you call it as neuroendocrine tumor. And if they are poorly differentiated, you call it as neuroendocrine carcinoma. So neuroendocrine tumor when it is well differentiated, and neuroendocrine carcinoma when it is poorly differentiated. And among this neuroendocrine tumor which is well differentiated, they are further subclassified based on their proliferative potential. Those with Ki67 index less than 3% is grade 1, 3 to 20% is grade 2, more than 20% is grade 3. Okay, this is as per the WHO 2019 guidelines. And they also give classification based on mitotic index. So mitotic index is just other measure of this proliferative activity, less than 2 mitosis per high power field, 2 to 20 and more than 20. The only difference is here Ki67 it is 3, mitotic index it is 2. There is one entity called Menon. So what do you mean by this Menon? It means mixed neuroendocrine and non-neuroendocrine tumor. That means that tumor has got neuroendocrine components as well as non-neuroendocrine components like adenocarcinoma. Okay, that lesion harbors both neuroendocrine tumor as well as a non-neuroendocrine tumor. That is what we call as Menon. That is also included in the current WHO classification of neuroendocrine tumors. So these neuroendocrine tumors commonly arises from the gut, and based on their origin, either from the foregut, midgut or hindgut, they have different properties also with regards to the biologic behavior as well as their secretory function. So the foregut neuroendocrine tumors takes their origin from either thymus, esophagus, lung, stomach, duodenum, and this pancreas is actually controversial. They are included more in midgut carcinoids, midgut neuroendocrine tumors. So the midgut neuroendocrine tumor include pancreatic, appendix, ileal, cecum and ascending colon, whereas the hindgut include distal bowel and rectum. And among this, the best prognosis is for hindgut carcinoids. So rectal carcinoids has the best prognosis, and the worst prognosis is for midgut carcinoids, midgut, especially pancreatic. Pancreatic neuroendocrine tumors has one of the worst. Does it mean that all neuroendocrine tumors in the pancreas has got worse prognosis? But the complication and the aggressive behavior is slightly on the higher side for pancreatic neuroendocrine tumors compared to others. And among the foregut, these thymic neuroendocrine tumors are more likely to be aggressive, thymic neuroendocrine tumors. But they are actually very less in proportion. Whereas midgut neuroendocrine tumors are the most common site. Midgut is the most common site. They are more aggressive compared to the hindgut, and the rectal carcinoids have best prognosis, and they are most often detected incidentally during colonoscopy. Now coming to the genetics and syndromes associated with neuroendocrine tumors, as you know, the most common genetic syndrome associated is the MEN1 syndrome due to menin gene mutation. You also have the MEN4 syndrome due to CDKN1B, and lot of other loss of heterozygosity and point mutations have been linked with neuroendocrine tumor genesis. One of those include SMAD4 and DPC4. So which are the genetic syndromes associated with neuroendocrine tumors? Of course, you have MEN1 and MEN4. Then you have von Hippel-Lindau syndrome, von Hippel-Lindau syndrome, tuberous sclerosis, and neurofibromatosis 1. So these are some of the syndromes which are associated with increased risk of neuroendocrine tumors. MEN1 and MEN4, of course, the most common neuroendocrine lesions include gastronoma as well as non-functioning neuroendocrine tumors. VHL is also more likely to have non-functioning neuroendocrine tumors. Tuberous sclerosis, again non-functioning. NF1, they have increased risk of somatostatinoma in pancreas and duodenum. Okay, so these are the important genetic factors as well as syndromes associated with neuroendocrine tumors. Now, what about the endocrine? Why do you say that they are having endocrine differentiation? Because they can release various secretory products that has endocrine function like serotonin, histamine, then so many tachykinins, kallikrein, and certain active endocrine hormones like ACTH, calcitonin, GHRH, CRH, etc. So many endocrinal active substances can be produced from these neuroendocrine tumors, which is testament to their endocrine function. But when you compare these set of hormones from these are more common. This production of ACTH, calcitonin, GHRH and CRH are relatively rare compared to serotonin, histamine, tachykinine, kallikrein, etc. And this is the serotonin metabolism pathway or synthesis pathway which is occurring in the neuroendocrine tumor. The precursor for serotonin synthesis is the amino acid tryptophan, and the rate limiting enzyme for this process is tryptophan hydroxylase. So it is the rate limiting step, and it converts it to hydroxytryptophan. Hydroxytryptophan is acted upon by the enzyme amino acid decarboxylase to produce 5-hydroxytryptamine, which is also known as serotonin. One important point with regards to this is that the foregut carcinoids lack this enzyme, this amino acid decarboxylase. This is not applicable to all the foregut carcinoids, but the usual trend is that the expression of this amino acid decarboxylase will be reduced or absent in foregut carcinoids. So that is the reason why the serotonin levels will be low. Serotonin levels will be low in foregut carcinoids, and they would have abundant amount of hydroxytryptophan. The hydroxytryptophan concentration will be high, but hydroxytryptamine or the serotonin concentration will be low due to the decreased levels of amino acid decarboxylase. And the end product of this serotonin metabolism is 5-hydroxyindole acetic acid or HIAA. The importance of HIAA is that to assess or analyze the secretory capacity of the neuroendocrine tumor, or even in the biochemical diagnosis of neuroendocrine tumors, we use the 24-hour urinary HIAA. 24-hour urinary hydroxyindole acetic acid is used in diagnostic purpose. Now, what about the secretory products with respect to tumor location? This is exactly the point I have just mentioned. In foregut carcinoids, there is decreased serotonin. Whereas in midgut carcinoids, the serotonin production is very much increased because there is higher expression of amino acid decarboxylase. Serotonin expression is increased. And one more point with respect to the tumor location and their drainage is that even though these midgut carcinoids produce so much of these metabolites, the serotonin, kallikrein, the bradykinins, etc., but they usually don't reach the systemic circulation. Why? Because whatever being produced from the midgut area, it goes to the portal circulation and goes to the liver. And these metabolites are catabolized by the liver, or liver causes clearance of these metabolites so that excess levels of these secretory active products are not reaching the systemic circulation. So in a patient with midgut carcinoid, usually they don't have manifest carcinoid syndrome unless they are having hepatic metastasis. If a patient with midgut carcinoid is having hepatic metastasis, what happens is that they would drain directly into the systemic circulation rather than to the portal circulation. So the secretory products from the metastatic lesion could then gain direct access to the systemic circulation, or due to the decreased function of the liver, the effective clearance of these materials would not be happening in patients with extensive hepatic metastasis. That is the reason why when a patient with midgut carcinoid starts developing features due to these secretory products, it is almost sure that he or she has developed hepatic metastasis. So midgut carcinoids, midgut neuroendocrine tumor develop carcinoid syndrome. Carcinoid syndrome is the name given to the constellation of signs and symptoms due to the elevated levels of these active peptides in the circulation. Develop carcinoid syndrome after liver metastasis. That is an important point. Whereas the neuroendocrine tumors in the bronchus and ovary. So these areas have direct access to the systemic circulation. So even lower amount of these active peptides which is being produced by the tumors in these locations can get access to the systemic circulation, thereby producing the symptoms. So bronchus and ovary directly drain into the systemic circulation, produce carcinoid syndrome, whereas midgut carcinoids, even though they produce so much of active peptides, they get metabolized within the liver, and only when these lesions metastasize to the liver, then only they would develop features of carcinoid syndrome. Now, clinical features of carcinoid syndromes, how are they going to manifest? So they mainly depend on the location, because as we have told, the secretory potential differs from the location, and therefore the manifestation would also differ. For example, bronchial carcinoid is not very metabolically active. They don't produce too much of secretory peptides. So they usually present with features of bronchial obstruction or hemoptysis, etc., or consolidation collapse, or sometimes they can result in increased histamine production with flushing, carcinoid syndrome and all. Whereas midgut carcinoid, the most common symptom would be abdominal pain, then it can result in intestinal obstruction, and the third most important presentation is the carcinoid syndrome. So it doesn't mean that if the patient is harboring a neuroendocrine tumor, he or she will invariably have carcinoid syndrome. It is not the case. In fact, carcinoid syndrome is seen in around 40 to 50% case of midgut carcinoids, and even lesser in neuroendocrine tumors of other location. So the highest chance of carcinoid syndrome is with midgut carcinoid, especially when there is liver metastasis, where 40 to 50% of the persons harboring metastatic entities will be developing carcinoid syndrome. Now, what are the secretory products responsible for the features in carcinoid syndrome? So, 3 or 4 characteristic features in carcinoid syndrome is the presence of flushing, bronchospasm, diarrhea, abdominal pain, etc. So the flushing mainly is mediated by the kallikrein, the bradykinin, the neuropeptide K, etc. The others also contribute to the flushing. Bronchospasm mainly by histamine and bradykinin, diarrhea mainly by serotonin. So, but again, this is not a hard and fast rule. I have given this reference as per what is given in Williams, but so many other references say that you cannot exactly pinpoint one clinical symptom to a particular metabolite. All of these act in conjunction. That is why you are getting various combinations of clinical features in a patient with carcinoid syndrome. Now, carcinoid syndrome is nothing but the combination of these features like flushing, bronchospasm, diarrhea, abdominal pain, hypotension, etc. So it refers to the signs and symptoms due to the systemic action of these vasoactive and peptides, which is expressed by the neuroendocrine tumors. Now, coming to the characteristic feature in carcinoid syndrome, which is flushing. There are 4 types of flushing which has been described, and I will tell you the most important points that you have to learn from that. So the erythematous is the hallmark flushing, where the patient would be having intermittent episodes of reddish hue over face, upper trunk and neck, and they are usually accompanied by other features like bronchospasm, abdominal pain, diarrhea, etc. So this is the most common pattern in intermittent carcinoid syndrome. And violaceous is seen in patients with chronic and persistent elevation of metabolites. In the first, the erythematous flushing would come and go in between whenever there is a precipitating factor, and the patient would suddenly experience the disturbance because it is associated with other features like bronchospasm, abdominal discomfort, chest discomfort, etc. Whereas violaceous means there is constant elevation of these neuroactive peptides, and therefore patient may not experience or patient may not know that he is having flushing. So usually it will be chronic and persistent, and a person may not be able to readily identify this violaceous flushing because due to long-standing exposure to these agents, they would have telangiectasia in the face. Facial telangiectasia is one of the features of this long-standing elevation of these substances. Then prolonged flushing means the flushing would last continuously for hours to days and up to a week. It is seen with malignant bronchial carcinoids. And finally, the bright red flushing is due to histamine produced from gastric enites. So once again, in intermittent episodes with other features of carcinoid syndrome, the patient would be having erythematous flushing and violaceous flushing in long-standing chronic elevation of these metabolites, prolonged in malignant bronchial neuroendocrine tumors where the flushing would last for days and weeks. Bright red flushing is mediated by histamine. The patient would also have associated bronchospasm. It is seen with gastric enterochromaffin cell hyperplasia. Now, what are the complications of this carcinoid syndrome? So, carcinoid syndrome, we have learned about a few symptoms, and apart from those symptoms, what are the other complications? One of the important feature is carcinoid heart disease. It's also known as Hedinger syndrome. And which are the affected areas? It is the right side of heart, because the lungs would metabolize. The left side of the heart receives blood from the lungs, and the lungs would metabolize all these active substances, so that the left side of the heart is usually spared of the effects of these active metabolites. That's the reason why the right side of the heart has got predilection, and especially the tricuspid valve and the pulmonary valve are the commoner areas which are involved, and TR is the most common valve lesion. Tricuspid regurgitation followed by pulmonary regurgitation, then you have tricuspid stenosis, then you have pulmonary stenosis. Okay, so all right-sided heart lesion and the valvular heart disease is possible, and the right-sided the myocardium also can be affected in long-standing disease. So what is the pathology there? Because these metabolites would cause upregulation of TGF beta, resulting in fibrosis. And the characteristic pathological abnormality is the deposition of collagen below the epithelial lining in endocardium. So in the endocardial layer, the deposition of collagen beneath the epithelial lining, that is said to be the pathologic hallmark or the gold standard pathologic feature characteristic of carcinoid heart disease. Now, how are you going to diagnose it? In a patient with neuroendocrine tumor and classical features, if you are getting features of right-sided heart failure like bipedal edema, raised JVP, tender hepatomegaly, anasarca, such features are there, you have to think of the possibility of carcinoid heart disease, and the typical biomarker is NT-proBNP. The cutoff use is more than 260 picogram per ml. So even in a patient who is not having any clinical symptoms, a patient with neuroendocrine tumor with NT-proBNP more than 260 picogram per ml, you should think in terms of an underlying carcinoid heart disease. And the severity of the disease is directly correlates with the 24-hour urinary HIAA, urinary hydroxyindole acetic acid. So the urinary HIAA is an indirect measure of the secretory potential of the tumor. So as this HIAA level increases, the chance of having severe carcinoid heart disease also increases. Now, how are you going to, and if you do the echocardiogram, you can identify the typical valvular heart disease and other structural abnormalities. So the treatment, you can give somatostatin analogs like octreotide, which will reduce the further progression of fibrosis, but the definitive treatment is surgery. You will have to go for valve replacement surgery provided the patient has got a life expectancy of more than 1 year and has got significant disability due to the disease process currently. So the valve replacement surgery is the definitive treatment, but you will have to make sure that it is followed up with a definitive management for the neuroendocrine tumor. And if the definitive management is not possible in a patient with extensive metastasis, if the complete resection is not possible, then you will have to keep the patient on somatostatin analogs so that the replaced valve also doesn't become susceptible to the increased carcinoid syndrome effect. So that is about carcinoid heart disease. Now carcinoid crisis. So carcinoid crisis is nothing but a severe form of carcinoid syndrome where the patient would be having severe hypotension, circulatory collapse, severe respiratory distress, etc. So whatever symptoms we have learned earlier, the severe forms of that is what we call as carcinoid crisis, and several precipitating factors like drugs, surgery, anesthesia, certain food items. So all these have been described as being causative for precipitation of a carcinoid crisis. Now, how are we going to treat a patient who is developing carcinoid crisis? That is by continuous IV infusion of octreotide. We will have to give 100 to 200 microgram per hour to control the further release of this active peptides, and thereby, and also hemodynamic resuscitation is also important. That is about carcinoid crisis, and it is also closely related to the levels of 24-hour hydroxyindole acetic acid. Now, what are the other features of carcinoid syndrome? We have seen that there is TGF beta mediated fibrosis in the heart, which is the cause for carcinoid heart disease. So this fibrosis can set in other areas also, especially retroperitoneal fibrosis. The patient can have mesenteric fibrosis, So this retroperitoneal fibrosis can result in ureteral obstruction, which can eventually result in renal dysfunction. So renal dysfunction occurring in carcinoid syndrome, either it could be part of the hypotension occurring in carcinoid crisis, or it could be retroperitoneal fibrosis, which is resulting in ureteral obstruction and causing renal dysfunction. Then pellagra is also a feature in a patient with carcinoid syndrome. Why? Because pellagra is due to niacin deficiency. So, and the source for this niacin in our body is tryptophan. So, niacin in our body is synthesized from tryptophan. In a normal individual, less than 1 to 2% of the total body store of tryptophan is used in neuroendocrine purpose. Okay, for neuroendocrine cells in our body, less than 1 to 2% of tryptophan is utilized for formation of serotonin and other active peptides. Whereas in patients with active carcinoid disease, more than 60% of tryptophan is utilized for serotonin production, and therefore there will be less availability of tryptophan for niacin production. So the patient would be having features of niacin deficiency in the form of pellagra, where the patient can have severe diarrhea, dermatitis, dementia, and can even lead to death. You call it as 4D phenomenon or 4D syndrome. Okay, diarrhea, dementia, dermatitis. The classical skin appearance, we call it as Castle's necklace. Everything can be seen in a patient with extensive disease or a large disease burden with neuroendocrine tumors due to channeling of this tryptophan to serotonin synthesis instead of niacin formation. Now coming specifically into pancreatic neuroendocrine tumors. So pancreatic neuroendocrine tumors can be functional or non-functional. The functional pancreatic neuroendocrine tumors, or PNET, we call them as PNETs. The functional tumors include gastrinoma, insulinoma, glucagonoma, somatostatinoma, VIPoma, etc. And you have non-functional pancreatic neuroendocrine tumors also. Now coming to individual, some of the few important points with regards to this individual pancreatic neuroendocrine tumors. The gastrinoma producing excessive, as the term indicates, it produces excessive gastrin. So the constellation of signs and symptoms due to a pancreatic neuroendocrine tumor overexpressing or overproducing gastrin is what we call as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is the term we use when a pancreatic neuroendocrine tumor overproduces gastrin, and the clinical features would be recurrent peptic ulcer due to excessive gastrin action. The patient can have diarrhea, malabsorption and steatorrhea. The patient can have weight loss, patient can have malnutrition, etc. So clinical features: recurrent or difficult to control peptic ulcers, recurrent peptic ulcers, diarrhea, steatorrhea, malabsorption, etc. And what about the biochemical diagnosis? The gold standard diagnosis is fasting gastrin level. Fasting gastrin more than 1000 picogram per ml with gastric pH of less than or equal to 2. So gastrin level should be more than 1000 picogram per ml with a gastric pH of less than or equal to 2. Why this gastric pH is important is because in patients with echlorhydria or who are on long-term PPI therapy, there will be enterochromaffin cell hyperplasia. Enterochromaffin hyperplasia in patients who are having echlorhydria. This enterochromaffin hyperplasia will result in increased gastrin. But this increased gastrin and this enterochromaffin hyperplasia is due to increased pH. So increased pH is a stimulator for enterochromaffin hyperplasia, and which can also result in increased gastrin. So high gastrin alone is not enough for the diagnosis of gastrinoma. High gastrin coupled with a low gastric pH is required. So suppose in a patient you are getting equivocal result. That means the gastrin elevation is not up to 1000 picogram per ml, but gastric pH is less. Or gastrin levels are 2000 or 3000, but the gastric pH is probably 3 or 4. In such situation where you still have diagnostic dilemma, you can use another stimulation test, which we call as secretin stimulation test. Secretin stimulation test. So in a patient with gastrinoma, giving exogenous secretin would further increase the gastrin levels, whereas in patients with secondary enterochromaffin hyperplasia, secondary to PPI use or echlorhydria will not have further increase in gastrin. So after giving secretin, if the gastrin level increases by more than 120 picogram per ml, you can confirm the diagnosis as gastrinoma. So after secretin, if the gastrin elevation is more than 120 picogram per ml, again that is confirmatory of gastrinoma. And about the location of gastrinoma, in 90% of the patients, this gastrinoma lesion is located within a gastrinoma triangle called Passaro's triangle. Okay, and this triangle is defined by the junction of common bile duct, neck and body of pancreas, and second and third portion of duodenum. So more than 80% of gastrinomas is found within the anatomic confines of this triangle. Now, the association of gastrinoma with MEN1, it is said that around 20 to 30% of all gastrinomas associated with MEN1. And MEN1 associated gastrinomas are more likely to be small, multiple, and intraduodenal, and they are aggressive also. So they are aggressive lesions, small, multiple, intraduodenal, and has got worse prognosis. Compared to a sporadic gastrinoma, those associated with MEN1 syndrome has got a worse prognosis. That is also one point to be noted. Now, what about the treatment? So treatment can be divided into medical and surgical. So medical is mainly for the symptomatic relief. The patient is having increased gastrin and increased acid production, severe GERD and peptic ulcerations. So they require round-the-clock proton pump inhibitor coverage. Round-the-clock proton pump inhibitor coverage with stronger ones like pantoprazole or omeprazole, rabiprazole, etc. And surgical treatment, when the size of the lesion is more than 2 cm, you go for resection. And the extent of resection is based on the location of the tumor. And in a patient with background MEN1, he or she is more likely to have hyperparathyroidism also. So hyperparathyroidism and increased calcium level will further increase the symptoms by increasing the gastrin levels. So controlling serum calcium is important. Controlling serum calcium either by parathyroidectomy or by cinacalcet is important in controlling the symptoms of gastrinoma also. So that is all regarding gastrinoma. Now about insulinoma. So insulinoma, the symptoms, as you know, patient will develop spontaneous hypoglycemia, and this hypoglycemia will be more during the fasting period than postprandial. Due to anabolic action of insulin, they will also have weight gain. Again, insulinoma is associated with MEN1, and the MEN1 associated insulinoma is more likely to be multiple and increased chance of malignancy. So usually this insulinoma is a benign lesion in 90% of cases. 90% of the cases, and most likely it is less than 1 centimeter. 90% of cases is less than 2 centimeter. 60% is less than 1 centimeter. That is about insulinoma, and they are located throughout the pancreas. There is no specific area of pancreas where there is site predilection. They can be located anywhere in the head, neck, body or tail. And regarding the imaging diagnosis, the CCT abdomen, MRI pancreas with contrast, and among the conventional imaging, the endoscopic ultrasound has got the highest sensitivity, more than 90%. Endoscopic ultrasound has got the highest sensitivity, especially in identifying lesions in the head and neck of pancreas. The lesions in the tail of the pancreas may be missed in endoscopic ultrasound. And regarding the functional scan, the nuclear medicine based scan, the gallium-68 extended PET has the highest sensitivity for detecting insulinoma. So gallium-68 extended PET. So extendin is nothing but a GLP-1 receptor analog. So this insulinomas has been found to be having rich density of GLP-1 receptor expression. So if you are using a analog to that GLP-1 receptor, then you will get increased sensitivity of detection of insulinoma, because these are small lesions likely to be missed by the conventional imaging. So if you are using a functional imaging, it is better to go for a gallium-68 extended PET scan rather than a gallium-68 dotted PET scan, whose sensitivity is only around 60 to 70% for identifying insulinoma. Now, what about glucagonoma? So, glucagonoma, we have seen that insulinoma is spread throughout the pancreas. It can be located anywhere, but glucagonoma is present more in the body and tail of pancreas. Why? Because that is the area where the alpha cells are more concentrated. The beta cells are distributed evenly throughout the pancreas, whereas alpha cells, the density is more in the body and tail. So that is where you are more likely to get a glucagonoma and more likely to be having a solitary large lesion more than 3 centimeter. It is more likely in a patient with glucagonoma. And what happens about the clinical features? So the clinical features, of course, because glucagon is the major counter-regulatory hormone, they would have uncontrolled diabetes mellitus. And this glucagon will channel all the amino acids to glucose production by gluconeogenesis. Okay, so there will be hypoaminoacidemia. And coupled with that, the patient would be having diarrhea and malabsorption. So this combination of this hypoaminoacidemia along with this malabsorption and nutrient deficiency results in some classical phenotypic manifestations. So this is the classical skin manifestation associated with glucagonoma, which is the necrolytic migratory erythema. Which is present around the mouth, in the flexural regions, in the perineal region, etc. So these are necrolytic migratory erythema. Also, the patient will have stomatitis, angular stomatitis, glossitis and cheilitis. This is mainly linked to the micronutrient deficiencies associated with glucagonoma. And the glucagon levels will also be more than 500 picogram per hour, which is also characteristic. And the other rare features associated with glucagonoma is the increased risk of thrombotic episodes, increased risk of pulmonary embolism. So when a patient with neuroendocrine tumor present with deep vein thrombosis or pulmonary embolism, you have to strongly suspect the possibility of an underlying glucagonoma. So glucagonoma is one neuroendocrine tumor which has got some characteristic abnormalities. You have hypoaminoacidemia, you have uncontrolled diabetes, you have thrombotic episodes, you have pulmonary embolism and characteristic skin lesion in the form of necrolytic migratory erythema. So these points you should keep in mind. Also, due to long-standing malnutrition, patient may also have severe anemia also. Now coming to VIPoma or the vasoactive intestinal peptide overexpressing lesion, it classically produces in a condition called pancreatic cholera or WDHA syndrome. WD means watery diarrhea, H means hypokalemia, A means echlorhydria. It's also known as Werner-Morrison syndrome. So this WDHA syndrome or Werner-Morrison syndrome is characterized by patient having severe watery diarrhea or severe small bowel diarrhea, watery diarrhea, hypokalemia and echlorhydria. Okay, and the plasma VIP levels above the upper limit of detection along with the suggestive clinical symptom and the identification of a neuroendocrine tumor is characteristic of VIPoma. Now last of the functioning neuroendocrine tumors, somatostatinoma. So The somatostatinoma is classically associated with a triad. You know that somatostatin is a natural inhibitor of most of the hormones physiologically. So when they are overexpressing, they would inhibit the action of insulin, resulting in diabetes. But the diabetes is usually mild because it inhibits glucagon also. It inhibits both insulin as well as glucagon. So the severity of the diabetes will not be as severe as seen in a glucagonoma. Diabetes mellitus, then steatoria, cholelithiasis. Why? Because the somatostatin inhibits the enzyme cholecystokinin, not the enzyme, the hormone cholecystokinin is also inhibited. So they result in gallbladder hypomotility, which is the cause for cholelithiasis. And one more important point with regards to somatostatinoma is its associations. So the important two associations of somatostatinoma, one is neurofibromatosis 1 and second is Pacak-Zwang syndrome. Pacak-Zwang syndrome, we have learned it under pheochromocytoma, which is due to HIF alpha overexpression. The patient would be having polycythemia along with pheochromocytoma and somatostatinoma. And neurofibromatosis also, it increases the risk of duodenal. The location of somatostatinoma in these two conditions will be duodenal somatostatinoma. Whereas sporadic somatostatinoma is more likely to be present in pancreas. Whereas the NF1 and Pacak-Zwang associated somatostatinoma is present in the duodenal location. And non-functioning neuroendocrine tumor, it is in fact the most common peanut in Men-1 syndrome. Previously, it was thought that gastronoma was the more common. Now, more and more with the advent of newer these functional investigations, functional imagings, it has been found that non-functioning peanut is the most common type of neuroendocrine tumor in a patient with Men-1, and it has got intermediate to poor prognosis and high risk of locoregional and distant spread. Very important. And some guidelines say that they should undergo resection when the size is more than 1 centimeter, because they have got significant chance of local lymph node as well as distant spread. So when they spread on to the distant areas, they become no longer curable. And in fact, this neuroendocrine tumor is the most common cause of death in a patient with Men-1 syndrome. Most common cause of death in a Men-1 syndrome patient is the advanced neuroendocrine tumors. Now, how are you going to diagnose a patient with neuroendocrine tumors? You have certain biochemical markers, and the most commonly used serum marker is chromogranin A. It has got sensitivity is good sensitivity, but specificity is not very good because chromogranin A can be elevated in other conditions other than neuroendocrine tumor, like PPI use. What happens in PPI use? PPI can result in echlorhydria, which will cause the chromaffin cell, enterochromaffin cell hyperplasia, which will overproduce gastrin. So this enterochromaffin cell hyperplasia will result in increased chromogranin A elevation. Okay. Then beta blocker use, renal failure, steroid use, all these can increase the chromogranin A levels. So it is not very sensitive. Then 24-hour urinary HIAA is considered as the most specific investigation. And the levels more than 10 milligram per 24 hours. 24-hour urinary hydroxyindole acetic acid levels more than 10 milligram in 24 hours is considered to be specific. But again, it cannot be called as a very sensitive investigation because, as I have told, in foregut carcinoids, in foregut NETs, this HIAA is more likely to be negative. Why? Because they don't express the enzyme amino acid decarboxylase. Apart from chromogranin A, you have other markers like chromogranin B is there, synaptophysin is there, neuropeptide K, the neuron specific enolase, so many other markers are also there. Then there is something called as a NET test. So NET test, it looks at circulating mRNA of 51 neuroendocrine tumor susceptibility genes. So NETest, they basically look at the genes which confers high risk of developing neuroendocrine tumors, and they look at the circulating levels of the mRNA transcript from these genes. So if they are found to be higher than a particular threshold concentration, then you can say that the patient could be harboring a neuroendocrine tumor. So this is especially useful both in the diagnosis as well as in the follow-up. With the use of treatment, you can know whether the concentration of these have reduced or not. So a question can be there, this NETest is used in the diagnosis or the follow-up of which condition? The answer is neuroendocrine tumor. Now, what are the conditions or what are the precautions that you should exercise before sending a 24-hour urinary HIAA test? There are certain medications and certain food items that can interfere with the HIAA assessment. The most important drug is acetaminophen or paracetamol. Paracetamol and caffeine and so many other drugs that we use commonly for our common cold, like decongestant medications, painkillers, then amphetamine, L-dopa, reserpine. So all these sympathetic activity related medications can interfere with the 5-HIAA assessment. So they need to be avoided at least 5 days before. So they should be stopped 5 days before testing. And during the time of testing, preferably at least 48 hours before testing, you should ask the patient to avoid these fruits like avocado, banana, then chocolate, coffee, pineapple, etc. So because these can stimulate the production of serotonin and can increase the release. Now, about the imaging in a patient with neuroendocrine tumor, you have two types of imaging. You have the anatomic and the functional. Anatomic mainly will give you idea regarding the location, what are the relation, any soft tissue infiltration, any distant spread is there, like information we get from anatomic imaging. They include CT and MRI. And MRI is preferred for liver. If you want to assess liver metastasis, then the best anatomic imaging would be MRI, and also bone. So early bone involvement and liver involvement is better assessed in MRI than CT, and the CT is preferred for lung and bronchus lesions. Contrast CT is the preferred one. Then you have the functional imaging, and the most common functional imaging used is the gallium-68 DOTA, and this is based on the expression of the somatostatin receptor 2, because the DOTA, gallium-68 dotatate PET scan, it binds to the somatostatin receptor 2 in the neuroendocrine tumors, and those areas expressing the somatostatin receptor 2 will light up during the scan. You also use gallium-68 exendin, as we have learned in insulinoma. In insulinoma, we use gallium-68 exendin PET scan. This is based on the GIP receptor. So this is a normal gallium-68 DOTA PET scan. So DOTA PET scan. So the physiological uptake is seen in the pituitary. You can see the area with the highest physiological uptake is spleen. Highest physiological uptake is seen in spleen. Also, liver takes up some. Adrenal medulla has physiological uptake. Then of course the kidneys and bladder, because it is excreted via the urine. So these are the areas of physiological uptake. In the brain, only pituitary glands takes up physiological uptake. And there is something called as a Krenning score. So Krenning score means that you are comparing the uptake in a target lesion compared to the physiological uptake. So if the score 0 means there is no uptake in any lesion. 1 means very low uptake. 2 means it is around the uptake seen in the liver. So this is the degree of uptake seen in the liver. If a lesion is showing an uptake similar to that of liver, you call it as grade 2 or score 2. Grade 3 means it is greater than that of liver but less than that of spleen. 4 means greater than that of spleen. So this is the semi-quantitative assessment of uptake in the lesions. It is what we call as Krenning score. So Krenning score, you compare the uptake of our target lesion or the lesion in question to that of the physiological uptake in liver as well as spleen. 0 is no uptake, 1 is very low uptake, 2 is uptake equal to that of liver or just less than that of liver, 3 is uptake greater than liver but less than spleen, grade 4 is the highest degree of uptake which is even more than the physiological uptake in spleen. So this is one example of gallium DOTA PET scan. So this is the physiological uptake in spleen, the physiological uptake in liver. Here you can see there is a pathologic lesion. So this is the kidney. These are the kidneys with physiological uptake. Here you have the pathologic lesion and the corresponding lesion is seen in the cross-sectional imaging also. Okay. There the lesion has got uptake which is higher than that of liver, but it is not as intense as that of spleen. So probably they will be having a Krenning score of 3. So that is how you assess the lesions. Suppose if there is a lesion which is metastatic to the liver, you will get a lesion like this in the liver. Likewise, you can identify multiple metastatic lesions. You can readily identify it using a functional scan. Now, how are you going to treat these patients? Treatment of patients with neuroendocrine tumors. You have surgical and non-surgical treatment. So, surgical treatment is done in patients who are surgically amenable. That means in a solitary lesion, non-metastatic lesion. In those individuals, you can do a curative surgery. But neuroendocrine tumors, the most common location is the midgut usually, and they usually don't produce symptoms unless they are metastatic. So whenever at the time of diagnosis, they are more likely to be in a metastatic fashion. A solitary lesion without any distant metastasis is less likely unless it is an incidentally detected when there is an imaging done for any other purpose. So that makes the management aspect of neuroendocrine tumor very difficult, cumbersome and crucial. So surgical, if it is a solitary lesion, curative resection. Even in a patient with locoregional spread and regional lymph node metastasis, then also you can consider surgery. Suppose there could be patients with extensive metastatic disease having severe carcinoid syndrome features, not responding to octreotide like that, and in such patients you can do surgical debulking to reduce the tumor burden so that the symptoms can be reduced. So that is about the surgical, and usually in midgut carcinoids, in pancreatic neuroendocrine tumors, you will have to do Whipple's procedure as a curative. Whipple's procedure as curative. And what about the non-surgical treatment? Non-surgical treatment, you have symptomatic and disease targeted treatment are available. Symptomatic treatment and disease targeted. And for diarrhea, you can give loperamide and anti-motility agents, and one specific agent which has been used in neuroendocrine tumor associated diarrhea is a drug called telotristat. So telotristat is a new drug which has been used to control severe diarrhea in a patient with carcinoid syndrome. So this telotristat is a tyrosine hydroxylase inhibitor. Tyrosine hydroxylase inhibitor. So when we have looked at the mediators which produces different symptoms, we have seen that serotonin is the one which is the major mediator of diarrhea. And which is the rate limiting enzyme in serotonin synthesis? It is tyrosine hydroxylase. So this telotristat, orally administered medication given twice or thrice daily per day, has been found to reduce the diarrheal episodes in a patient who is having difficult to control symptoms. So that is one of the newer advances with respect to medical management of neuroendocrine tumors are concerned. So about the disease targeted non-surgical management in a patient with extensive or surgically inamenable neuroendocrine tumor, you have two. One is the somatostatin analogs, and second is what we call as PRRT. So PRRT means peptide receptor radionuclide therapy. Radionuclide therapy. So first we'll discuss about somatostatin receptor analogs. The octreotide or the lanreotide that you are giving will bind to the somatostatin receptor expressed in the tumor surface. So they will have an effect both by reducing the metabolic activity, by reducing this substance production from the lesion, as well as it also slows down the proliferative potential of the tumor to a particular extent. But these are not extremely effective in reducing the tumor progression, and in around 2/3 of the cases, it can result in the reduction in the tumor progression, but it will not result in tumor resolution or tumor regression. It will help you to prevent the faster progression. That is all regarding the somatostatin analog use. But PRRT is a recently introduced novel therapeutic approach for management of metastatic neuroendocrine tumors. So as the name indicates, peptide receptor radionuclide therapy. So this is nothing but a targeted radiotherapy. The problem with the radiotherapy, the conventional radiotherapy that we have been using in tumors in other locations, was that they produces significant bystander effect. That means even though we are focusing on our target tissue, but that will deliver inadvertent radiation effects into the surrounding tissues. Surrounding healthy tissues are also damaged, and that will cause long-term health consequences in that individual. But in this PRRT, what we are doing is that we are keeping a radioactive substance, and here this radioactive substance is the lutetium-177. Lutetium-177 that can emit beta rays. And this lutetium-177 is linked with a somatostatin analog. So it is linked with a somatostatin analog, and it is administered as IV infusion to the individual. So what happens when this lutetium-177, which is a radioactive material, which is a source of beta rays, is linked with octreotide or any somatostatin analog? They will go into the circulation, and this somatostatin analog will concentrate maximally on the areas where the somatostatin receptor 2, SSTR2, is expressed. And where is it expressed? It is expressed abundantly in the neuroendocrine tumor surface. So what happens? These are the cancer cells that expresses the somatostatin receptors. So this lutetium-177 bound with octreotide or somatostatin analog binds to the receptor, and the somatostatin analog will gain entry into the cell. Okay, it will gain entry into the cell, and once this complex reaches inside the cell, this lutetium-177 will start emitting the beta radiation. So thereby you are getting a targeted tissue destruction. The normal tissues are not taking up this lutetium-177 because they don't express somatostatin receptor type 2. So that is the advantage of this PRRT. You are able to achieve targeted tissue destruction and targeted radiation delivery. So currently the standard PRRT that we are using is lutetium-177 octreotide PRRT. This octreotide is the somatostatin analog that is conjugated with lutetium-177. Previously there was an yttrium-90 PRRT. So this PRRT has been found to have tumor size reduction potential, and it has been proved to be better or to be having better efficacy than somatostatin analogs in arresting the tumor progression. So summarizing, we have learned about the basics in neuroendocrine tumor, their location, how are they classified, what are the secretory products, and what is the clinical features of those secretory product excess. We have looked at carcinoid syndrome, what are the clinical features, the types of flushing, what are the other features associated with carcinoid syndrome. We have looked at the carcinoid heart disease, the manifestation, diagnosis and management. Then we have seen about the pancreatic neuroendocrine tumors, each of the individual ones, the insulinoma, gastrinoma, glucagonoma, somatostatinoma and all. And we have seen about the diagnosis, the biochemical methods for diagnosis and their fallacies. And also we have looked at the imaging modalities, mainly focusing on the gallium DOTA PET scan, the physiologic uptake and the pathological correlation. And finally, we have looked at the various modalities for treatment, including somatostatin analogs and PRRT.